Hi everyone, thanks for joining me today. My name is Rachel Taves. I'm a nurse practitioner with physical medicine and rehab at St. Luke's Hospital here in Cedar Rapids. I work for Dr. Stanley Matthew, and I am going to be talking to you about hypermobile Ehlers-Danlos syndrome today. So before we get started, I just wanted to briefly introduce myself. I grew up outside of Iowa City. I attended Mount Mercy University and graduated in 2015 with my BSN. And then I went on to get my master's at Allen College and graduated in 2019. I took my first job at a post-acute rehab facility / long-term care facility called Manor Care, is now ProMedica. And then about 2 years later, I got approached about coming in and working in the physical medicine rehab clinic. So I took that job and I started in January. Since January, I have been working in the clinic. I work Monday through Friday, and then I also have been working as a hospitalist to help out, and also I do vet disability exams, and I do hospice recertification exams. So needless to say, I keep myself pretty busy. So the reason I want to talk to you about hypermobile Ehlers-Danlos syndrome, also known as HEDS, and that's what I'll be using for short from here on out, just because it's a mouthful, is because I was actually diagnosed with HEDS about 4 years ago. So kind of a little bit of my pain journey. When I was 10, I was diagnosed with chronic back pain of unknown origin. My provider told me to work out and to lose a little bit of weight, and that would help my back pain when I was 10 years old. And when I got into junior high, I was swimming and I pushed off the side of the pool, and I didn't turn my foot or anything like that, and I had like severe pain afterwards. And I actually ended up doing track for 6 weeks after that, and then they finally did an MRI 12 weeks later, and they found that I had a complete bucket torn meniscus on my left side, so I had surgery for that. And then when I was 2015, I woke up one morning, had a really sore knee. I had gone for a walk the day before, and I sprained my ankle. And I did therapy again, and I knew exactly what was going on. I went in, they did another MRI, and I had a second right bucket torn meniscus and had surgery for that, except for they repaired it. And then in 2019, I was walking, I slipped on some food on the ground, and I completely tore the repair that he had done. So I have no meniscus on either one of my knees, and there was no known traumatic injury. I got diagnosed with a degenerative cartilage disorder of unknown origin from orthopedics, and that was kind of that for a while. Since then, I've been diagnosed with pelvic floor dysfunction, chronic migraines, and cervical dystonia. So kind of all these weird medical things that occur when someone has HEDS. So again, with all my medical background and my medical history, this is kind of why I wanted to continue to learn more about hypermobile Ehlers-Danlos syndrome, and also to educate and be able to appropriately diagnose it. So today I hope to provide you with information that you need to understand this population, but more importantly, to be able to take care of them. So I'm going to go over the objectives here. So you can click. Let's talk about that. Sorry, next slide. Perfect. So what is hypermobile Ehlers-Danlos syndrome? What are the different mobility categories? List the common objective signs for patients in the clinic with HEDS. How is HEDS diagnosed? List contradictions of physical therapy interventions for patients with HEDS. Identify symptom management techniques for patients with HEDS. Next slide. So what is HEDS? HEDS is a connective tissue disorder that mainly affects the joint and skin. And we really don't understand a lot about this or the pathophysiology behind this yet. But what we do know is that there is some kind of defect with the collagen, which is making the connective tissue overly flexible. So this is an autosomal dominant disorder, meaning that you more than likely inherited this from a close relative, such as your mom or your dad. There are 14 different types of EDS, and this is the only type that there's no genetic testing for. So the other 13 categories have a genetic test that you can do to see if you have it. The other thing with HEDS is that about 50% of parents will pass it to their child. So if you have 3 children, one of your 3 will get EDS. So there's also a study that was done recently that said it takes an average of 10 to 20 years to properly get diagnosed with HEDS. And this is because patients often are dismissed when they come into a clinic or their primary care doctor and have all these very random, vague symptoms that are going on. And then HEDS is more common in females than males, but we do know that males tend to become less flexible quicker compared to females, and that's probably because when they're younger, your mom finds out you're flexible, your dad finds out you're flexible, and they're like, let's put you in dance, let's put you in gymnastics, like this is something that you'd be good at. And then for males, obviously, that's not usually what happens. So, and then the last thing I wanna talk about is the fact that everyone with HEDS has their own form of misery, is what I like to call it. So everyone has their own issues, their own symptoms, and their own other medical conditions that are going on. Next slide, please. So before I dive into HEDS, I want to talk about the most common problems that you see. So the first problem is chronic pain or injuries with or without trauma, usually without trauma. The second is TMJ pain. So you may have someone who has clicking, popping, ear pain in the morning, difficulty eating, chewing. Sometimes it affects their muscles in their neck, and sometimes it causes migraines. And then the third is autonomic dysfunction. So you have your syncope episodes, pre-syncope episodes, dizziness, headaches, lightheadedness, and then you have your POTS, your postural orthostatic tachycardia. And then you also have some people that have orthostasis. The next one is GI dysfunction. So you might have issues like nausea, vomiting, diarrhea, constipation, or a mix of any of those, and then also abdominal pain. They have found that there is some correlation to already having a diagnosis of IBS, Crohn's disease, ulcerative colitis, or food intolerances. And the fifth is chronic migraines, headaches, so usually related to that craniocervical instability that I'll talk about. The sixth is easy bruising and bleeding. So you may have a patient that has bruises everywhere and they don't know when or where they occurred or how they occurred. The seventh is anxiety or panic disorder, and we also know that a high percent of patients with HEDS will also have a diagnosis of ADD or ADHD. And then lastly, chronic fatigue. So you'll probably have a patient that says, I'm tired all the time, but there's no rhyme or reason to why. Next slide, please. So for the purpose of this presentation, I'm not going to be going over all the range of systems, but I just wanted to let you know that hypermobile Ehlers-Danlos literally affects every system in the body because we have connective tissue everywhere. So I'm going to go over the types of hypermobility. So you have your generalized hypermobility. So this would be somebody who has like fingers, flexibility, elbows, knees, neck. You have your peripheral hypermobility, which is usually your hands and your feet. You have your localized hypermobility, so that could be like one joint location or one joint. So you could have like someone who just has hypermobility in their knees or even one knee or one joint. And then you have your asymptomatic hypermobility, your historic hypermobility. So this is somebody that does not meet the hypermobility score, but they have all the other factors that you would look at when trying to diagnose someone with hypermobile Ehlers-Danlos syndrome. And then you have your asymptomatic hypermobility, which pretty much means that they don't have any symptoms of hypermobility, but they will say like, I have easy bruising, bleeding, I have chronic fatigue, I have an anxiety or panic disorder. And then we also know that there's some studies done that show that there may be some correlation with fibromyalgia, irritable bowel syndrome, postural orthostatic tachycardia syndrome, irritable bladder, also known as pelvic floor dysfunction. But again, a lot of this is not well understood yet. Okay, next slide, please. So each of the previous types of hypermobility involving having some type of muscle manifestation. So what are those? So you have your most obvious one, which is pain. So this can be caused by a muscle soft tissue trauma, dislocations, subluxations, and microtraumas. Microtraumas are injuries which result from frequent repetitive use of that muscle, which I'm sure you guys are aware of. Can also be tendons, ligaments, joints, and bones. And this can include small tears in the fiber and the connective tissue, as well as sprained ligaments, muscle, and overstretched tendons. So you have your very common manifestation of disturbed proprioception. So that's meaning that the body's sense of where it is in space and the effort that is needed to move to that desired space doesn't work too well. So patients with HEDS are often labeled as clumsy and tend to trip upstairs, not down, and run into stationary objects. And then your last muscle manifestation is other types of musculoskeletal or orthopedic traits, such as flat feet, misaligned bones in the elbows and toes, and an abnormal curvature of the spine. So to briefly touch base again with some of the different systems involved that you may experience taking care of a person with HEDS, you have your musculoskeletal cranial cervical instability, which can lead to cervical medullary syndrome. So that's the compression on the lower part of the brain. This can cause like a heavy bobble head-like feeling, headaches, tachycardia, heat intolerance, syncope, orthostasis, chronic fatigue, neck pain, and numbness at different parts of the body. And this list can go on and on and on. And then these symptoms are also very similar to Chiari malformation. So then you have your other symptoms that include muscle knots, early onset arthritis, muscle spasms, hypertonicity, your subluxations, dislocations, tears, and then the joint instability. Oh, that's blurry. Okay, I actually have that slide for you guys on it's the Beighton score there. Yep. So let's talk briefly about how providers diagnose HEDS. So HEDS is diagnosed strictly on clinical presentation and assessment of a patient. So the first criteria is the Beighton score, and based on the age, they need to score between a 4 and a 6 out of the 9 points. The second criteria is looking at other medical problems such as derm, dental, and cardiovascular involvement. And if they don't meet criteria 2A, you move on to B and C, which is a positive family history for chronic pain, hypermobility, and then also you have your chronic pain questions on the bottom there in category C. And then the other thing that providers want to make sure that they're doing is ruling out any like rheumatology or autoimmune disorders. So we usually get a full autoimmune panel. Some other information regarding the diagnosis of HEDS is that HEDS and classical EDS have very similar symptoms. So if you have a patient that has any cardiac symptoms, it's important for them to get referred off to cardiology to get an EKG and an echo done. So what happens is if their EKG or their echo comes back abnormal, there's a very certain criteria that you have to hit in order to get that genetic testing done. So usually the cardiologist will order the EKG and the echo, and they'll kind of go from there. And if cardiology needs to manage them, if they have any cardiovascular symptoms, then they'll be following with cardiology as well. So now let's talk about the different treatments for HEDS. So please keep in mind that a diagnosis of HEDS should have a multidisciplinary approach. So this should include your PT, your OT, podiatry, osteopaths, sports medicine, pain psychologists, psychiatrists, and any other specialists that they may need to be involved in their care based on what symptoms that they have and what other medical conditions are present. So each patient should have an individual problem-solving approach and plan, as each patient with HEDS will have a different area that may need attention. So there's still a lot of research that needs to be done regarding HEDS, but there are some key factors that therapists need to focus on. So these include soft tissue work, gentle mobilization, electrotherapy, joint stability, improvement in endurance, strength, posture, balance, and coordination. And all of this should be done at a steady 6 to 8 week program. So before I go over it in an introduction program for therapy for HEDS, I want to talk to you about why I see patients coming back into the clinic after trying therapy. And usually they say, Rachel, I tried therapy like you told me to, and I got so much worse. Like, I'm so much more painful. That was a bad idea. You know, I don't want to come back in. There's a lot of reasons why I hear this, so I want to kind of just discuss with you some of those reasons. So the first thing is to always let your patient know that this is going to be a slow process, right? And I'm sure that you guys do this anyway, but just reiterating the fact that your pain is not going to go away in 2 weeks. This is going to be a slow, steady journey for you, especially with someone who has HEDS, because you need to start from the very beginning. Secondly, I will run into this problem a lot where a patient, for example, has cervical cranial instability and they have like that neck tightness. So if you start with doing strengthening exercises for somebody who has already, an issue with like tight muscles, and we continue to try to strengthen them, that's in turn only going to make them worse, and it's going to make their pain worse. So there's things that you can do first to obviously help try to get them to relax their muscles. You can do dry needling, cupping, massage, acupuncture, and then in the clinic we do things like Botox and use muscle relaxers to try to get them to relax first before we can go ahead and get them to strengthen. The other thing that I just wanted to talk about was Botox in patients with hypermobile Ehlers-Danlos syndrome. So you have to be really careful because people who have HEDS, when they get Botox, it tends to spread outside of what it's intended to stay into the muscle. So you can have patients that have had Botox, including myself, that have had paralysis as a result of the toxins spreading to an unattended muscle. So if you ever see it in the clinic where someone comes in and they have like weakness and you're like, where did this come from? You can always ask them like, have you had Botox in the last 3 months? And usually their answer will be yes. And then you can, reiterate that this will wear off over time, but it can cause extreme weakness for a while. So the other thing I want to talk to you about with patients with hypermobile Ehlers-Danlos syndrome is there are a lot of patients that will go through cycles of pain. So for example, say tomorrow I vacuumed, I did the dishes, I mowed the lawn, I went out and I gardened. The next day I'm going to be extremely, extremely painful. I'm going to take the whole day off and rest. And then come the following day, I'm gonna be fine. And then I'm gonna repeat this cycle. So I'm gonna repeat this cycle over and over again because I'm doing too much in a small amount of time. So it's important for patients when they're doing physical therapy to avoid like repetitive exercises to space everything out. You always want to think quality over quantity for their exercise program. So based on the research done, I will go over the main key concepts to take away for when you have a patient with HEDS. So step 1 is improving the trunk stability. So starting with the low back. So due to that joint instability and the lack of joint control, you have that altered posture that occurs due to that instability. So this causes that pain to those deep postural muscles that often become overloaded. And then due to the lack of support over time, this changes that muscle activation signal in the brain and the cortex, which is responsible for that sensory input. So these changes need to be reversed. And the exercise should target a specific part of movement that requires that greater skill and precision. So the motor skill training should be pain-free to prevent the motor cortex from getting overly excited, and that in turn hinders that learning process. The rehab program should be goal-oriented, and like I said, quality over quantity should always be a part of that program to help prevent fatigue and flare-ups. Step 2, you have your muscle strengthening. So patients usually come in a deconditioned state due to that decreased physical activity due to pain. They also may have like an injury, or they just have poor posture in general. Some research shows that patients with HEDS actually need to work harder due to that joint instability, and they have found that patients with HEDS tend to use their knees more and less of their gluteal muscles for posture. So improving that strength and dynamic muscle control helps support and decrease that trauma to the joints. So you want to start with like static exercises in the hypermobile range first before progressing to that dynamic work and restricted work. If you start in that normal range, you will cause more pain, and this can be extremely uncomfortable for someone whose body is used to being in that hypermobile range. Another important thing is to start with non-weight bearing and work up to weight bearing. So aqua therapy is actually a really good option for a patient needing to be in therapy but can't quite tolerate ground therapy. And then step 3, you have your external support, such as the use of bracing and other forms of aid. So bracing should not cause any muscle weakness because it's just going around the joint and supporting the joint. But this should also be avoided unless someone has like an acute injury going on or has better movement or proprioception with the use of a brace. And then the last step is balance and proprioception. So this is such as working with like a balance board, sitting on an exercise ball, and then also it's important for your patients to wear like tight-fitted clothing when they come in for physical therapy sessions to help with that proprioception disorder. And then the other thing too that I have found helpful is the use of KT taping those joints for stability. And then the last thing too is there is some research out regarding scapular dyskinesis, also known as sixth scapula syndrome, but there isn't anything that is showing that it is 100% correlated with EDS, but we do find that a lot of patients that come into the clinic have that shoulder weakness, kind of that abnormal movement and pain. So let's summarize what we discussed. We know that HEDS is a complex medical condition that requires a multidisciplinary approach involving several types of specialists. It pretty much involves every part of your body. Everyone with EDS has their own symptoms and their own medical issues. And then the steps to improve the overall therapy performance, tell them it's gonna be a slow process. Always think quality over quantity. Start non-weight bearing and start in their hypomobile range first.